Hello. It's January 17th, 2025, and this is the end of the week. So I've compiled a few topics from this week's mychart messages to talk about rather than going through them and just reading them and then reading my reply and then typing. I just picked a few and I'll just talk about those briefly and go through those, see if that's valuable. And hopefully the lighting good. I'm going to keep the lights on, unlike last time. So let's get started. It was kind of a busy week, man. I had a jam-packed schedule and I just had a really hard time keeping up with stuff. So it's been a lot of later nights in the evening, but we are at the end. So one of the questions was, why is my blood sugar high in the morning? You know, they can go hours and hours without eating, yet they wake up and their blood sugar's in the 180s, 200s, and they're just curious as to why that could happen. So it has a lot to do with the pancreas and the liver. The pancreas is responsible for releasing glucagon, which tells the liver to make more blood sugar available in the bloodstream, and insulin, which lowers blood sugar. So in diabetes, everything's screwed up with blood sugar. So you may not be pumping out as much insulin as you need to, or you may be the glucagon and blood sugar that you're releasing into your body that's stored in the liver may not be adequate. And then the two organs aren't talking to each other well. So you need blood sugar, you need glucose to be able to feed your organs, and especially high metabolic ones like the brain and heart. So you can't be going for too long without a steady stream of glucose. So that's why it's so important to have blood sugars in a certain range. But in diabetes, everything's just screwed up, and you can have abnormal levels of those chemicals, and then you can also have a bad response. So that's how you can have a 250 blood sugar despite not having eaten anything for 18 hours. And then another thing that I talked to a few patients about this week was the triad of treatment for diabetes. So every diabetic patient needs to have something for diabetes, and that can be diet, or it can be one medicine, or it can be 5 medicines, but something for diabetes. A certain type of blood pressure medicine called an ACE inhibitor or an ARB to help protect the kidneys and control blood pressure. And then the third thing is a statin. A statin, like Lipitor, is a cholesterol-lowering medicine that's important not just for cholesterol lowering. And in diabetes, we do need to have much tighter control of cholesterol, because with diabetes increasing the glucose levels, that's a pro-inflammatory state, and it increases cardiovascular risk, increases heart attack risk, increases stroke risk. So we need to be really strict with cholesterol lowering. Depending on the patient, less than 70 or less than 100. So we can do that with a statin, but we also want those statins on board to stabilize cholesterol plaques. So you can have, if this is a blood vessel and you start getting cholesterol plaques built up on the sides, they just keep on building up, and then you can have those plaques on either side, and that can cause a blockage. So we want to stabilize those plaques so they don't get sticky with platelets and form a clot or a blockage that could lead to a heart attack or stroke. So got to get that triad going. I had a patient just today who was on something for diabetes, was on that certain type of blood pressure pill to protect the kidneys, but he wasn't on a statin. His cholesterol had been excellent in like the 50s, but I talked to him today about that plaque stabilization, and he was willing to start one, even though his numbers were great. So those are important for diabetes. The next one, pain management. So what can be done to control my pain was the question. Pain management is tricky. So back when I first started in medicine, a primary care provider like me could manage somebody's pain. We could prescribe opiates if necessary on an ongoing manner, and it wasn't a big deal. Well, then came the opiate crisis kind of came before I came along, but it was just kind of ramping up. But the opiate crisis really got into the full swing, and it really became a crisis, overdosing and worse with those kind of medicines. So a lot of restrictions were placed on those types of medicines. And really it became it became extremely difficult for most providers to manage chronic pain with opiates. So we would have to send patients elsewhere, whether it's a pain clinic or orthopedics to fix whatever musculoskeletal problem was wrong. But even then, we started running into problems with fewer and fewer pain management sites actually managing chronic pain with opiates. And not that everybody needs that, but people are able to get pain relief with opiates, and they can kind of dose themselves with the frequency of the medicine they're taking. So fewer and fewer providers are doing that. Most of them are going towards pain injections, which is sometimes helpful for people, sometimes not. So it's really, really hard to get people in to get the care they need. We can treat acute pain, but chronic Vicodin or Percocet or whatever ongoing is just not really doable for most providers. So that patient and I talked about a strategy, but it's just really frustrating to get patients the help they need. And it's often not the patient's fault that they're in pain or that we're running into problems getting them in with somebody. It's just they're stuck without many options, and they suffer as a result. So really unfortunate. And the last one I'll talk about is prior authorizations, the bane of our existence. Again, when I started off, well, actually, no, before I started off, this was decades ago. A provider could prescribe a medicine or order a test, and it just is paid for. Oh, you're the doctor, you're the nurse practitioner, you're the physician assistant. You ordered this thing. All right, we'll pay for it as the insurance company. That's not the case. If it's a brand name medication, and brand name medicines in general are either more effective or better tolerated. So sometimes we have to lean on those for better outcomes for our patients. And because insurance companies have more power than they used to, they can kind of dictate what we do. So we might send in a prescription for brand name medicine, and the insurance company will say, no, you need to prove to us why we should pay for this. You need to do a prior authorization. Well, as if my prescribing of the medicine wasn't authorization enough, clearly I feel that the patient would benefit from this medicine. I or one of my staff has to go through and answer a series of questions. What has the patient been on before? Have they been on cheaper options? Have they been on options that were likely not as applicable for them? Are they appropriate for the medicine? Do they have the right diagnosis? Are they a reasonable patient? All these kind of things. And even when we take the time to go through that question answer period, they can still deny it, and then we're stuck. If the patient's not going to be able to afford the medication, there's nothing we can do, and they might have to go to an inferior or inappropriate option. So I had that. I mean, we get prior authorization requests all the time, and we do a pretty decent job of being able to get those covered. The real headache is when an imaging test requires a prior authorization. A lot of times that's due to a patient needing to do physical therapy first or do some other maybe appropriate, maybe not, cheaper test. A lot of times it's doing an x-ray before an MRI and doing so many weeks of physical therapy. That's the most common thing, which is reasonable, I suppose, in a lot of respects. But sometimes the patient has already done those things, or it's there's more of an urgent need to go straight to a more advanced test. And a lot of times, if the prior authorization doesn't get accepted, they request a peer-to-peer. Those are super fun. So that's where the insurance company is demanding that I, as the provider who knows the patient, who believes this test is appropriate, has to plead my case and my patient's case that this test is warranted. So I have to take time out of my day where I could otherwise be helping my patients or spending with my family and calling this doctor who has no knowledge of the patient besides a list of medical problems in front of them. And they have a bunch of buzzwords and keywords that they can use to deny that patient. And we have a patient saying, hello, hello. So the prior authorization situation is extremely frustrating, especially when you get shot down by this doctor who doesn't know your patient and you can't get the test I need. One time I had a patient who had died of cancer, and we did a CT scan of the lungs to see the progression of the cancer, and they denied the test. The patient died from a condition that we were looking at with that test, and they refused to pay for it even after her death of that cancer. It's just ridiculous. So that's the kind of stuff we have to deal with, and we're happy to go to bat for our patients, but even we have our hands tied behind our back sometimes. So those are just some of the things that came across this week. I have a sick child at home, so I'm probably going to head out right now. Feel free to throw up a like if this is worthwhile. I can keep maybe trying to do these on Fridays as I've got the time, and certainly add some comments if you like some other topics covered. But if not, I'll take some stuff from my chart, because those seem to be questions that come up more often than not. I hope everybody has a great weekend. I'll see you next time.